Greetings everyone from Advanced Fertility. Today I'm going to talk about a very interesting and sometimes a very commonly asked question when fertility treatment is ongoing. Today we are going to discuss about IUI. What is IUI? IUI means intrauterine insemination. So again, this series will be divided into three parts. One is I will be discussing which are the couples who do best with IUI. The next series will be regarding some frequently asked questions about IUI. And the last would be sharing some recent scientific studies on IUI. So today we are going to talk about patient selection before IUI. IUI involves processing of the sperm in the laboratory and then directly placing it into the uterus, as you can see in this diagram. So naturally the sperms are released here, and then the sperm has to go up and meet the egg somewhere in the fallopian tube, and the egg needs to come into the fallopian tube first, and then fertilization, embryo formation, and implantation. In IUI, we are timing the ovulation, and then we are putting the sperms closer to the egg, hoping that the best sperm will eventually meet the egg. Before we start this process, we need to evaluate, assess, explain the treatment cycle, and consent regarding the treatment process. Which are the couples that will benefit from IUI? Women with ovulation disorder, polycystic ovaries being very common, coital dysfunction where physical relationship is not possible or is not frequent enough, male factor where the sperm count and motility is suboptimal, unexplained, and in some women with endometriosis. So in these cases, we can propose IUI to a subgroup of these patients. Not all of them will get conception with IUI. So how do we select which ones will have the best results? We need to take a history, we need to do physical examination, we need to do some investigations. Now, in the investigations, we need hemoglobin, thyroid, blood sugar, and hormonal levels, anti-Müllerian hormone, hepatitis B, C, HIV, and the recent semen analysis. If any of the parameters like blood sugar, thyroid is not in the normal range, then it must be corrected before treatment is started. Again, the egg reserve needs to be near normal for good success rates in IUI. We need to do an ultrasound in the beginning part of the cycle, the follicular phase, early follicular, to check the ovaries, the antral follicle count, to rule out cysts, fibroids, polyps, and also in the middle of the cycle, around day 15 in a natural cycle, to be sure that the endometrium is good, trilaminar, and at least more than 8 millimeters. If we find these, then chances with IUI success will be higher. The ovarian function, as I said, the antral follicle count should be at least more than 8 to 10. The AMH should be ideally more than 1.5 nanograms per milliliters. And if we find a cyst in the beginning part of the cycle, we need to do estradiol levels to be sure that if the estradiol levels are low, then we can start with the treatment process. Good ovarian reserve can lead to better success. Of course, the tubes need to be checked. If the tubes are not patent, then success with IUI will be low. For example, in hysterosalpingography must be done, or a sonosalpingography, or better still, laparoscopy. Now, in a young couple, we need not do tubal stress directly, especially if the duration of trial is only a few months and there is no history of pelvic inflammatory disease. But if one or maybe two IUIs fail, and if we have decided to persevere with IUI, then tubal evaluation is a must. Laparoscopy is a mini surgery that is done under anesthesia, takes about an hour, and it is an excellent fertility enhancing procedure to evaluate the uterus, the tubes, and in polycystic ovaries, do ovarian drilling, and in endometriosis, removed the chocolate cysts, especially if it is in the first time. It gives a very good idea of tubal health, and in cases where the tubes are minimally to moderately damaged, even corrective surgery can be done at the same sitting. So evaluation is done to improve outcome. If we select the patients well, our success rates both in IUI and in IVF will be higher. So, for example, if one of the tubes is grossly dilated and there is water or fluid collected in this tube called hydrosalpinx, then fertility success will be low naturally with IUI or with IVF. It is always wise to put in a telescope and clip the corresponding tube which is collecting with the fluid that may be toxic to the growing embryos. Fibroid. Now, there are three kinds of fibroid. One is outside the uterus, one is in the wall, and one is jutting into the cavity. Not all fibroids need removal, but definitely the ones jutting into the cavity need to be out. The ones in the wall, if they are large, especially with multiple treatment failure, in my opinion, especially if they are more than 4 centimeter, also need to be out. The ones that are subserous may be left. Ovarian cyst is a chocolate cyst, and that, for example, endometriosis. The menstrual blood, instead of going, has a backflow and collects in the ovary. And if it is a first time, a young couple, surgery may be beneficial and then can be followed with IUI. Before doing the IUI, we need to be sure that the passage into the cavity is clear. A per speculum examination is a must. Any history of difficult cannulation, for example, a difficult tubal test, must be taken seriously, and a mock embryo transfer, in this case IUI cannula, should be inserted to be sure that the passage is clear and we are not struggling at the time of IUI. Whether we should do hysteroscopy before IUI is being contentious, and the advantages are there definitely before IVF, but sometimes in difficult cases where there is long-standing infertility, there is suspicion of pelvic pathology, hysteroscopy may be useful before we start with the IUI. The sperm parameters. Now, many a times there are couples who come with very low sperm count and ask for IUI as a solution. We must understand that IUI can only be done when the sperm parameters are normal or just suboptimal. In very poor sperm analysis, IUI is usually not successful, and we need advanced methods like IVF or ICSI, intracytoplasmic sperm injection. As you can see in the latest edition, the total sperm count of 39 million per m and a concentration of 15 million per m and motility and morphology, these are the normal ranges. So the more normal the sperm is, the better would be our results. Sperms can be prepared in different methods in the laboratory to pick the best motile sperms and then to be injected into the uterine cavity. The TMSC, which is the total motile sperm count, if it is close to 10 to 15 million, gives us the best results. So we have done the evaluation and assessment. Now we go to explaining the treatment cycle. We have to tell our couples what it is. What actually we are doing with IUI is just an advanced version of natural trying. The rest of the system of the sperm meeting the egg, fertilization, it traveling down from the fallopian tube into the uterus, all these systems still have to work naturally for pregnancy. The number of visits are usually anywhere between 3 to 5. The procedure is usually like an ultrasound scan. A gentle instrument is inserted, takes about 15 minutes, usually painless, but in women where there is vaginismus or who are extremely apprehensive, we do it under mild anesthesia. Success rates, very important. So a natural success rate in a couple is usually 10 to 20% per month. Now, if a woman is not conceiving for more than 1 year after trying naturally, her per month pregnancy rates are very low, probably 5 to 10% or even less. With IUI, it can be 10, maximum 20% per month. The cumulative pregnancy rate in a young patient with patent tubes, reasonable eggs, reasonable sperm, in 3 to 6 attempts can go up to 50-55%. But these are only in the good prognosis patients. So the overall expectations from an IUI treatment must be very clear. We must sign the consents of the couple, explaining them the procedure and explaining them the treatment process and also the consent that we are using the husband's sperm. In rare cases, we may use donor sperm when husband is azoospermia or zero sperm count and couple have given us consent for the same. The cost of the treatment varying from city to city varies between 5,000 to 20,000 per cycle. So this is the treatment chart. Your period starts, we give the medication or sometimes injection. For 7 to 8 days, ultrasound is done. On the 8th day, 10th day, insemination is done on the 12th day. Medications to support are given for 2 weeks and the pregnancy test. So this is an average treatment cycle for IUI. If you have short cycles, it will happen earlier. If you have longer cycles, it will happen later. And this is how we monitor at our center, what medications, age, your tubal status, what day of the cycle, what are the follicle sizes on the right or the left, and then when we do the procedure, and then the medications for support. So we must remember age. The younger you are, the better are your results. So really 32, 33 is still when you should wait, provided your egg reserves are going good. After that, do not wait and go ahead with fertility treatment to give you the best results, especially if you've tried for more than a year. Age, duration of trying, and previous treatment and associated factors. Like, have you had medication? Do you have PCO, endometriosis, sperm factor? All these decide what is your overall chance to get pregnant? So, which are the patients which will conceive easily? It's a no-brainer. The young women, the women with less duration of fertility, good sperms, patent tubes, ovulatory dysfunction, fewer treatment attempts, and no associated pathology. Which are the poor prognosis? Older patients, longer duration, one tube blocked, probably the other is also not functioning. Tubes are not like a pipe, open or close. The entire IVF laboratory is inside a tube. Movement of the egg, fertilization, the sperm meeting the egg, the embryo forming, embryo going back, everything happens in the tube. Tube is a very important structure for natural or IUI conception. And if one is damaged, probably there's an issue with the other one too. Long treatment history and presence of adhesions, infections, these are all very poor sperm count are factors for reduced pregnancy outcome. So I hope you've had an interesting few minutes to learn or share my ideas on IUI. Please write down your comments and any queries if you may have any. And then we will be discussing about some frequently asked questions of IUI in our next series. So thank you so much, and till we meet next. Bye-bye.